Hi, good afternoon, and thank you for that lovely introduction. It's a real pleasure to be with you all here today, and thank you for the lovely warm welcome to Saudi that I've received. This is the first of two lectures that I'll be giving you over the next 2 days, and I hope to get the opportunity to meet many of you during the course of this conference. So when I was planning this talk, I was thinking about some of the things that our two countries have in common. And there was one hurdle that I couldn't get past, and that was the weather, unfortunately. So in Sheffield, which is in the north of England, we had pretty bad weather over the last few days, and I was slightly concerned that I wouldn't make it to my flight, which was rather delayed. You can see how much snow fell. This is my back garden over the course of 24 hours that all fell. So I was delighted to land in Riyadh, and it was lovely and warm here, so that was a real delight. But in dentistry, we do have some things in common. We both have huge populations of children and young people. In the UK, we have nearly 7 million children aged under 19 years. Here in Saudi, you have even more. You have nearly over 10 million children and young people to treat, so huge numbers. We're both really fortunate in that we have really comprehensive healthcare systems. We have our National Health Service in the UK, you have your Ministry of Health. But we also have one other thing in common, and unfortunately, that is caries. And we're not on our own in this. This is a global problem. 60 to 90% of children around the world have got caries. It's the most common disease worldwide. And that's why the theme of this conference is so important today. So I'm keen to give you an overview of the current evidence base for three different approaches to prevention that I think are all really important. And I'm going to be using some examples from the UK just to illustrate some ways that you can go about this. So first of all, I want to talk about prevention at home. So every 10 years in the UK, we carry out a national survey of children aged 5 years old, 12 years old, and 15 years old. And we use this data to plot trends in the number of children with dental caries. But for the first time ever, we recently, in 2014, we undertook a survey of 3-year-olds' dental health. And unfortunately, the results were pretty shocking. We found that 12% of 3-year-olds have already got decay either into dentine, perhaps they've needed fillings, or they've had to have teeth extracted due to caries. So really quite poor figures. So we decided to take some action with this. So the British Society of Paediatric Dentistry, we launched a campaign to encourage something that actually we have known for quite a while. We wanted to encourage children to be brought to the dentist before their first birthday. So this campaign has been quite successful. You'll see the Twitter hashtag. We've been trying to spread the word of dental check by one, DC by one. And the reason for this is that it gives us an opportunity to deliver some really important messages for children before their first birthday. So even though we're not going to be carrying out any clinical prevention, perhaps at this time, we can at least give families those important messages. So what messages are we wanting to give? Well, first of all, fluoride toothpastes. We know that fluoride toothpastes are effective in reducing caries. 37% reduction in caries in the primary dentition, 24% reduction in the permanent dentition. These are incredible figures, and we need to get that message out there. So parents need to be using a fluoride toothpaste. We also know that there is absolutely no evidence that plaque removal alone can prevent, control, or reverse caries. It's the fluoride that is the most important aspect. So we need to get that message to parents, and we need to advise them to use fluoride toothpaste appropriately as well. And there are a number of factors that do affect the effectiveness of fluoride toothpastes. the frequency of the use of the toothpaste, we know that brushing twice a day reduces caries by a further 14% when compared with just once a day. So we need to be encouraging families to carry out this twice daily brushing. And the concentration of the toothpaste is also really important. For every increase in concentration of 1,000 parts per million fluoride, there's a further 8% reduction in caries. So again, we advise children under 3 years of age to use at least 1,000 parts per million fluoride, and children over 3 years of age to use 1,450 parts per million of fluoride. And just as a note, for any of you who are not familiar with the symbol, the blue circle symbol, this is the sign of the Cochrane collaboration. So these are Cochrane reviews, the highest form of evidence. So this is really strong evidence that we have. We also know that rinsing your mouth with a large volume of water after brushing your teeth will mean that you're more likely to have a higher DMFS increment. You're more likely to have caries compared to children who maybe rinse their mouth with just a small amount of water or no water at all. So this is another message. We have to advise families not to let your child rinse their mouth out with water afterwards. It's a really important message, and it can improve their outcomes. So what about the amount of toothpaste that's used? Well, as you can see on this slide, the increment difference in caries experience between using a large amount of toothpaste compared to using a small amount of toothpaste, it's not significant. So that's why we advise children under 3 years of age just to use a smear of toothpaste, and children over 3 years of age to use a pea-size amount, so just a small amount. We don't need anything more than that. Otherwise, we start to worry about the risks of fluorosis and toxicity, and there's no need for that. We can get a really good outcome just from using a small amount of toothpaste. So really important messages to get across. And just by giving families these messages, we can make a huge difference. We can convert them from being in a suboptimal toothbrushing regime to being in an optimal toothbrushing regime. And that can make a 40 to 50% difference in prevention, just from getting families to change these habits. So although we're not doing any clinical treatment, we are giving really important advice. Of course, diet. We know diet is a really important factor in dental caries, and we have to encourage our families to reduce the amount and frequency of sugar consumption. And it is particularly drinks at bedtime that are doing the damage, and drinks that are sipped throughout the day. The Department of Health in the UK have recently released this child-friendly app for children to download onto their phones and iPads. And the beauty of it is you can take it into the supermarket, you can scan any product on the supermarket aisles, and you can find out the number of sugar cubes worth of sugar that that product has inside. So it's trying to engage children to take a bit more responsibility for what they're eating, as well as families. And the other thing that I think is really important is to ensure that families are aware of the need to use sugar-free medications, particularly children who are on long-term medications, to try and write to their doctors and ask them to try and swap them onto a sugar-free version of their medication. Really can make a difference. So is there anything else that we advise for people to use for prevention at home in the UK for children? We know that there is evidence that fluoride gels for home use, they do make a difference. However, in the UK we feel that this is adding in another factor that can sometimes confuse families. We wanted to just stick to the facts of the toothpaste and try and encourage families to use that as the first line. And also fluoride supplements, again, we have lots of evidence to say how they are effective, but they do rely on parents delivering the appropriate amount of fluoride. It's compliance that is the issue, and also the risks of overdose and toxicity as well. So we are not advising anything else other than those key messages. So what about clinical prevention? So our mainstay of clinical prevention is fluoride varnish. We have absolutely loads of evidence to show how effective it is in both the primary and the permanent dentition. We also know it's pretty cheap. It's very well accepted as well. There's very few risks. I'm sure many of you are aware that perhaps some patients with respiratory problems or asthma, certain brands of fluoride varnish are not suitable for these patients because the fluoride contains colophony, which can trigger an asthma attack. However, there are now brands available where the colophony has been removed, so these brands are safe for patients with respiratory problems as well. So there's no excuse to not provide fluoride varnish. And the beauty of it is that we can train up our dental nurses, our dental assistants, to apply the fluoride varnish as well and get them involved. So here is our evidence. Again, Cochrane reviews, really high quality evidence. We know that these fluoride varnishes work. 37% reduction in primary teeth and a 43% reduction in permanent teeth. You know, massive amounts. We just need to keep applying it. So what about fissure sealants? Well, we've got loads of evidence to say that these work as well. Does it matter which material we use, composite resin or GIC? Well, no, the Cochrane review said that there was no benefit of one type of sealant over another. Although the retention rates are different, there was no difference in the outcome of caries or no caries. So it doesn't matter. But we know that sealants can prevent caries. So which one's best, fissure sealants or fluoride varnish? Well, we know that the Cochrane review, which was from 2010, found that sealants have a better reduction in caries incidence than 6-monthly fluoride. However, there is quite a recent study just last year from Wales in the United Kingdom, quite a large-scale study. They looked at over 1,000 children aged 6 to 7 years from very deprived parts of the country. Half of the group received sealants on their first permanent molars, and half of the group received fluoride varnish on a 6-monthly basis. And they found that there was no significant difference between the groups at 36 months. So neither one is better than the other, but of course if we can provide both, then we have an even better chance of preventing caries. So what about any other clinical prevention? Is there anything else that we might be using in the UK? Well, the slow-release fluoride beads, which you may be familiar with here, there's a lot of research from the University of Leeds in the United Kingdom on these. So they are a device that's cemented onto the buccal aspect of the upper right first permanent molar, and they are intended to release fluoride on a slow rate over a course of time. The Cochrane review again says that there is the potential for some effectiveness from these, but there are problems with retention. A lot of these beads tend to fall off, and as a result of that, lots of the research has a high potential for bias as well. There are some problems with that. So these are not something that we are routinely using in their current state. And as our previous speaker was discussing silver diamine fluoride, myself and my colleagues from Sheffield, we went to the International Association of Pediatric Dentistry conference in Chile last year, and everybody was talking about silver diamine fluoride except for us, and it was quite embarrassing. We realized we're actually probably quite behind the times. The American Association of Pediatric Dentistry, they have already released their guidelines on the use of silver diamine fluoride. We have nothing in the UK as yet. We are working on it and we are reviewing the evidence. There certainly does seem to be some benefit from this material, so we are looking into it. So what about community-based oral health promotion? So in the UK, dental caries is a disease of the poor, so I can't comment on the situation in any other countries, but in the UK it tends to be families in deprived areas who have the greatest experience of caries. We know this from research where we use 2 different indicators to identify whether a child is from a deprived family. Children whose families receive benefits from the government to support them are often eligible for free school meals. So when we do research with children, the children who are on free school meals, they are the ones that we know are from deprived backgrounds. And we can also check children's postcode or zip code, and we can find out whether they live in quite a poor community, a poor area of the country. And unfortunately, children who are eligible for free school meals are much less likely to have good oral health. So only 29% of children who are eligible for free school meals have good overall oral health, compared to 40% of children who are not eligible. So there is a really big divide. And that's something that our community oral health promotion programs are really trying hard to tackle, to try and reduce those inequalities. So I think it's important when you're thinking about community-based approaches to ensure that we have a combination of what we call upstream and downstream interventions. So downstream interventions are things like your clinical prevention, your education, whereas your upstream interventions tend to be things on a much higher level, your government, your national policy changes to try and improve children's oral health. But it's really important, the research does show us that you need to have a combination of changes right at the very top level, and also keeping up that clinical prevention from the downstream approaches to get a really good outcome. So what is oral health promotion? Well, the World Health Organization defines it as enabling people to take control over the determinants of health and thereby improve their health. So what we want to try and do is create an environment for families where they can actually start to make a difference to their own oral health. The World Health Organization agreed an international agreement on health promotion called the Ottawa Charter. And it has five components to it, and I want to just briefly talk through the 5 components and some examples that we're using in the UK to try and tackle these. So first of all, the first part of the Charter is to create a supportive environment. So we have the Cochrane review, we know that water fluoridation from 0.7 to 1 part per million fluoride can create a reduction in DMFT quite significantly as well. We know that water fluoridation works. It can increase the number of children without caries by 15%, which is huge, really, really effective. So why don't we use it everywhere? Well, we have some parts of the UK which are have artificial water fluoridation. Some areas have natural water fluoridation. We always keep a close monitor on the level of fluoride within the water. But there is some resistance to water fluoridation, and one factor is that we have quite a bit of research that shows that 0.7 parts per million of fluoride, so a really low dose, can give a 12% chance of developing fluorosis that could give aesthetic concerns. So one issue I have with this research, whilst I think it's very important, a lot of these research projects tend to be very large-scale studies, and they often use a very brief examination to identify whether a child has enamel opacities, and any enamel opacity will be recorded as fluorosis. Now, this is not a criticism of the researchers. I'm not sure if I could think of a better way to tackle it, but we have to appreciate that these studies have a really high risk of bias. If you look at a child with an enamel opacity without taking a full fluoride history, social history, genetic history, all of these different components, and medical history, how do we know for sure that it is fluorosis? Could it not be molar incisor hypermineralization? Could it be a mild form of amelogenesis imperfecta? It could be hyperplasia. Perhaps the primary teeth had an infection that we don't know about. It could be something chronological. Of course, it could be fluorosis, but we just don't know. And a lot of these research projects will just take a brief examination without getting the whole background and without checking the rest of the dentition as well. So we have to bear that in mind before we just start to panic about the risk of fluorosis. I just feel that the risk of fluorosis from such a low level of water fluoridation, I just don't believe it's as high as 12%. I find it very hard to believe. So the next factor of the Ottawa Charter is called healthy public policy. So this is something that we are just about to introduce in the UK, and it's sugar tax. And we know from research which was supported by the World Health Organization by Paula Moynihan in Newcastle University in the UK, they found that dental caries is lower when free sugars are less than 10% of the total energy intake. So what are free sugars? Well, these are sugars that are added by manufacturers. So it doesn't matter about the natural sugars in a product, it's the free sugars that cause the damage. So these could be just added sugar for flavoring, it could be syrups, honeys, these sort of things that are just added. But they really do some damage. So we also have some research to suggest that a 20% sugary drinks tax is likely to reduce the consumption of fizzy drinks. It's likely to decrease obesity, which is important as we think about health overall. It's likely to reduce the incidence of caries as well. So why are we only just thinking about this? What's the resistance? And unfortunately, there is a lot of resistance as well, even to sugar tax. A lot of people feel that the government is taking control, we're babying the population. It's what they call a nanny state. We're sort of being too controlling in making products that families like more expensive. But companies are already starting to reduce the amount of sugar in their sugary drinks. So we are actually already making a difference. We know that various manufacturers are already reducing the quantity of sugar. They're changing their recipes of their products. So it is making a difference already. There are some companies which are starting to try and find a way around it. So, for instance, Coca-Cola have already launched 3 new drinks in the UK with recipes. So they've got just the amount of sugar just so that they don't have to pay the tax. So they're trying to be very clever about it. I worry that there is still a lot of sugar in these drinks, even if there's not enough to charge the tax. However, we have to accept it is a step in the right direction. It's not a solution, but it's a step forward. The other factor of the Ottawa Charter is about strengthening community action. So I mentioned before about how fluoride varnish can be applied by dental nurses. We're giving them extra training to provide education as well on oral health. But I'm thinking now about the wider professional workforce. Why are we just thinking about dental professionals? What about children's centres? So these are like a nursery that we use, most families would use them in the UK. And we are now focusing on training up children's centres to provide toothbrushing for children at one opportunity during every day. So children will at least get their teeth brushed once a day and supervised by the children's centre staff. We're also training school nurses to be more aware of oral health and to try and adapt children's diet within schools as well, taking away vending machines, selling fizzy drinks, these sort of factors. We're trying to advise pharmacists to try and persuade families to avoid selling those sugary medications to them, to try and promote the sugar-free versions. We're also trying to encourage sports coaches to discourage the children that they're looking after from bringing sugary sports drinks, energy drinks, to their football classes, or what is it? These are really good opportunities because we have so many patients, especially young boys, who'll come into the clinic. They'll say, "Oh yes, I have 3 energy drinks a week when I'm at football." Even if we can just get them to swap from sugary energy drink just to water, it makes a huge difference. It really does. And of course, hospital staff. We're starting to train our hospital staff to take really good care of children's oral hygiene whilst children are perhaps receiving care for cancer treatment. The last thing you want is to have a child getting a dental abscess or a dental infection whilst they're already poorly. It's just something we want to avoid. So getting hospital staff engaged has been a real priority. And we also have 2 groups of health professionals who visit families in their homes. These tend to be families who have problems. Perhaps they're from more deprived areas. Perhaps there are some issues within the family. But these 2 groups of professionals, health visitors and social workers, they are really, really key in delivering those messages to families and children in their homes. The 4th part of the Ottawa Charter is about developing personal skills. So our national guidance in the UK advises parental supervised toothbrushing. So we advise that children's teeth are brushed by a parent until they are about 7 or 8 years of age. We don't believe that children have the manual dexterity to do a decent job of toothbrushing until they're a little bit older. Obviously, as the child gets older, we would want the child to take over a little bit more, but the parent should still be monitoring everything closely. Despite this guidance, we know that half of 5-year-olds in our country don't have any supervision when they're brushing their teeth, which is a real shame because parental supervised toothbrushing can lead to a 15% reduction in caries, which is a really, really important amount. So myself and the team in Sheffield, we carried out a qualitative research study with parents of children who are under the age of 6. And these were families in quite deprived areas. And we carried out qualitative interviews with these parents and used the theoretical domains framework, which I'm not sure if you're familiar with, but it's very useful for any projects about behaviour change. And then we analysed all of the findings. And it was really interesting. We found that parents tended to have a really good detailed knowledge about toothbrushing. They knew that they had to do the toothbrushing, but they didn't know about the guidelines. A lot of these parents had experienced really negative dental experiences in the past. Perhaps they were traumatized by these experiences, and this motivated them to take better care of their children's teeth. But it also made them worry about their children's teeth as well. We found that lots of these families had very, very busy daily lives. They were rushing to get the children ready to school, rushing to get to work, all of these sort of factors, and sometimes toothbrushing got forgotten about. Most parents said that they were fine brushing their child's teeth. They had no problems up until the age of about 18 months when things started to get a little bit difficult. And as you can see from this quote at the bottom, this lady said, "My 2-year-old, if I try to brush it for him, he'll throw a tantrum. He throws the toothbrush at me, he throws the toothpaste at me, he just lays on the floor and starts kicking his legs." And I'm sure many of you may have experienced this sort of situation yourselves. It's really, really difficult, and what happens at this stage is parents tend to take a step back. They tend to not want that confrontation in the mornings, and they tend to take more of a supervisory role. So you can see at the quotation at the top, it says, "Me do it, me do it." So I'm like, okay, we'll make sure you do the back ones. So the mum's just saying, okay, you take over, that's all right. Just make sure you do the back ones, which is not what the guidelines say. Obviously, we want that hands-on approach, but parents find it really, really difficult, and they don't have the confidence in dealing with these tricky situations. So what did we do? Well, we developed 2 interventions, and we developed these with parents. So we got parents on board to help us find out what would work best. And these were all based on psychological theories of behavior change. The first intervention is one that was delivered by all health visitors. So these visit children and see children from the age of 0 to 3 years old. And the health visitors would deliver those key messages on how to deal with the toothbrushing when the child reaches that difficult age of about 18 months. So really practical advice on what to do. And we also have a targeted program, a targeted intervention. So we already have lots of systems in place where parents can attend parenting classes to give them practical support. And we integrated this toothbrushing into those classes. So we gave parents real hands-on opportunity to practice toothbrushing and dealing with those tricky situations. So at the minute, these programs are just run locally in our area, but we're hoping that if we find these are successful, it's still early days, but if we find it makes a difference, then we're hoping we can roll these out nationally. And the final part of the Ottawa Charter is about reorientating health services. So some of you may be aware that we have a few programs running in the UK. Northern Ireland has the Happy Smiles program. Wales has a program called Designed to Smile. In England, we have a program called Smile for Life, but the biggest and the best and the most famous is Child Smile in Scotland. And this program has received a number of commendations for the dramatic change that they have managed to make in children's health. So these programs are all government funded, and the aim of these programs, as I say before, is to reduce those inequalities, to make sure every child has access to good oral health promotion. So with the Child Smile program, every child receives a free flow feeder cup by the age of 1. So this is to prevent the use of the bottle and beakers, because we know that this can lead to an increase in bottle caries. Every child will receive toothbrushes and toothpaste packs at least 6 times before they reach 5 years of age. So again, families who perhaps don't have very much money, they can still get access to these really important instruments. And every child will receive supervised toothbrushing at nursery. So these are really important things. There's also a separate component of Child Smile where they have trained up special dental health support workers and also extended duty dental nurses. So as I mentioned before, these are dental nurses who have received training to provide oral health education and apply topical fluoride varnish as well. And what the support workers do is that they will identify children in schools who are not registered with a dentist, and they will link them up with a dental practice and put them in touch with each other, and then that child is registered with that dentist and will receive regular appointments through the post. These Child Smile practices are all accredited. All of the dentists in the scheme are aware of the whole purpose of prevention being the most important thing. And they provide examinations every 6 months, fluoride varnish every 6 months, and they'll give advice as needed. And the final aspect of Child Smile is a targeted programme. So this is aimed at the most deprived areas of Scotland. And these children will not only receive supervised toothbrushing in nurseries, but also in primary school as well. So the teachers are trained to supervise the toothbrushing during these early years in school. And also there will be a dental nurse with these extended duties that will go into their schools and apply the fluoride varnish in the school setting. So it takes away the need for families to take their child to the dentist. So what's the evidence? Well, there's absolutely loads. From 2006 to 2014, a 14% increase in primary school children with no obvious decay. I mean, the evidence speaks for itself. It clearly works. 92% of children in Scotland are registered with a dentist. They're having regular reviews, they're getting the fluoride varnish. It's going to make a huge difference. They've also found that these nurses with extra skills have got a really high level of job satisfaction as well. They're happy with their job. They like having this extra responsibility as well. And the latest figures suggest that Child Smile is saving our National Health Service £5 million a year in treatment costs. Think what that £5 million could be used for instead. It's fantastic. It's not a perfect system. There are still some challenges. We know that in the UK we have about 45,500 hidden children. So when we say hidden children, these are children who do not attend schools, perhaps they're from traveling families, perhaps they're homeschooled, but these are children that our government, our systems, our education systems, and our healthcare systems find very difficult to access. And so these children are missing out on all the benefits of programs like Child Smile. So we have to figure out still how we can access these families. We also know the UK, it's a very multicultural country. We have families from all around the world. There are some language barriers in delivering our messages. So whilst we try to produce leaflets in different languages for families, it's not the same as hearing the messages directly. And unfortunately, we do know that families living in the UK where the mother doesn't speak English, we know that these families have a higher incidence of dental caries than those where the mother does speak English. So language skills are really, really important, but it is a barrier to these families receiving those messages. And of course, in Scotland, it's quite a hilly place. There's lots of countryside. It's very rural. And sometimes these families are very isolated. They literally live in the middle of nowhere. So it's how do we get those messages to those families? It's not like we can drag them to the dentist, all the time and deliver the messages there. So it's how do we tackle this? So there are some challenges for the future. But I hope you will agree that Child Smile does demonstrate a really successful and cost-effective community-based approach to oral health promotion through reorientating health services. So just to summarise, I think you'll all agree that evidence-based prevention is so important to improving oral health. And I do think this multifaceted approach is really important, having the at-home prevention, the clinical prevention, and policy changes, really big changes from higher up as well, that can really support the community in a positive way. I think they're all very important, and hopefully we'll see some good results in the future. Thank you, everybody, for listening anyway. I'm happy to take any questions.
Thank you, Dr. Helen, for your nice presentation. We really enjoy your presentation and how smooth you were. Really thank you for this. And on behalf of the organizing committee, I would like to present this certificate of appreciation. Please.
We will open the floor for 2 or 1 question. Yes. Excuse me, دكتورة. تفضلي. Excuse you, Dr. Helen, for 1 more question.
Of course.
Dr. Hiba Al-Karimi, I'm a public health dentist consultant. Thank you very much for your presentation. I'm happy that you talk about upstream and downstream approach, because here in Saudi Arabia, we usually go to downstream and victim blaming people about their education and whatever. My question is, you talked about the sugar in medication. Do you have any policy in UK to control that? Because what you said is you talk to parents, but I haven't heard that you have a policy.
Yeah, you're absolutely right. So we know that there are sugar-free versions of almost all medications that dentists prescribe. We know that they are available, and they are in our prescribing formulary. We have I presume you have something similar, like a book of all the medicines that you can prescribe. We have tried to encourage our medical counterparts to try and prescribe the sugar-free medications in preference to the sugary medications, but actually getting that message to them has been quite difficult. they are quite reluctant to change their patients' medications, particularly if they're long-term medications. They're very reluctant to change. So what we often do is write a letter to them and ask them. But so many times I've had responses back where they've said, the medication's only got a little bit of sugar in it. And I keep saying it's not the amount, it's the frequency. These children are taking these medications every day, 3 times a day. That's 3 episodes of sugar that they're having, which could be avoided. So it's actually educating the medics in that it's the frequency of sugar that is most important. I hope at some point we can have a policy for the medics, but I'm also keen for there to be more training for the undergraduate medics as well, so during their training program of medicine, to try and incorporate something into their curriculum about their role in preventing tooth decay.
But so far we are tackling people, but not the policy, which I believe you have to tackle the policy. So still you have a problem.
Still, we're trying, but you're absolutely right. It's a big challenge. I hope we will make some progress at some point.
You have very good people in public health in UK. I think you should work on it.
I think that's a very good idea. I'll tell them.
Thank you.
Thank you.
Thank you, Doctor.
Thank you.
Now we'll start the next presentation. Dr. Elias Perdozes. Dr. Perdozes received his dental degree from National and Capodistran University of Athens Dental School, and his certificate in pediatric dentistry and master in oral biology from University of Medicine and Dentistry of New Jersey, United States of America, and PhD from the University of Athens Dental School. He has worked as a research fellow at Brookhaven Laboratories in New York. He is working at his private practice limited to pediatric dentistry and orthodontics, and as a part-time clinical instructor at the University of Athens Dental School. He has taken part into European research projects and one national pathfinder study for the oral health status and treatment need in Greek population. He has published in national and international journals and has lectured in national and international congresses and seminars. His primary interest in dental informatics, caries diagnosis and prevention. He is also co-author in the textbook of Dental Informatics, Principle, Means and Applications. Dr. Perdozes has served as a Secretary and Vice President of Hellenic Academy of Pediatric Dentistry, and currently is a Secretary of the European Academy of Pediatric Dentistry. Please join me welcoming Dr. Perdozes.
Good afternoon. Thank you very much for the introduction. It is a great pleasure for me to be here with you. It's my second trip to Riyadh, and it's always a pleasure to meet new friends and new friends I've made all during the past couple of years I am in the area. I would like to thank the scientific committee for giving me the opportunity to be here with you this afternoon. What I will try to do in the next few minutes, I will try to communicate with you some information from a national study we did in Greece in 2014, and we're still manipulating the data, calculating and making results out of the data. It is. We will talk about the health status and treatment needs of 5, 12, and 15-year-old Greek children. Before I go on, I would like to acknowledge some of the people that are dealt with the program. Of course, this is, as I said, is a national program. The coordinator is Professor Ulis from the University of Athens. It was done under the auspices of Hellenic Dental Association. Both dental schools took was part of the study from the School of Athens, Dental School of Athens in Thessaloniki, and it was this it was sponsored by the European Fund. This is just, I put it here just to give a tribute to all the people that they've worked for this program. And as you can see, there are many, and there are some more that are not included here from the company that did the administrative part. So all these studies are very copious, time-consuming, and they need a lot of designing. The purpose of these studies is to provide information about oral status of the country, evaluate the prevalence of oral disease and the delivery of treatment. And, I think the ultimate goal is to evaluate these data and try to do significant intervention in their society. Something that, like Dr. Rogers were talking about before. A little bit of history. The first pathfinder study in Greece was done back in 1985. It was from World Health Organization and the Ministry of Health. It was in an age group of 7, 12, and then 34 to 44 years old population in 16 districts. And the second one was in 2004, the same group that we did the 2014, we did the 2004 study. We had the same groups, which is standard now in the literature, the 5, 12, 15-year-old, 13 to 35 to 44, and 65 to 74-year-old. In 11 districts of the country. Of course, here we will present only the data from the kids. The purpose is, again, to investigate the oral status, update the epidemiological status, and finally, contributing to the changing of the oral health environment of the country. I will discuss primarily the data we have and the results we have from the caries in this group. But also, my main purpose is to discuss a little bit the design, what we try to innovate in this study, and what is left after the study is done. So the different stages is, of course, we need the approval of the authorities. Then there is a survey design, the calibration of the examiners, which is a very sensitive and very important part of studies like this. The examination and data collection, the statistical analysis, of course, the evaluation of the data. So the study went through the ethics committee of the University of Athens and the Ministry of Education. The sample selection, we used the same 11 districts that we used in the first study of 2004. Initially, they were randomly selected in the first study, and we used the same area so we can have some direct comparisons between the two studies. We had 15 urban and 9 rural areas from these districts. The schools that we visited were not the same as the first study. They were randomly selected from the same areas only. And the inclusion criteria to be someone in the study was to be in the age group, of course. There should be healthy, Greek nationality, written parental consent, and no fixed appliances. As a side study, we evaluated also immigrants in Greece, but we're not going to present it here today. The design of the study, we used the ICDAS standard for this study. This is an innovation that there are not that many epidemiological studies that they use ICDAS 2 as the means to record the caries. We did that for many reasons. We'll talk a little bit about it further down. We try to combine different groups of the ICDAS index and try to form the DMFT index from the ICDAS. And the decay component of the DMFS or DMFT index, we pulled together the data from ICDAS 3, 4, 5, and 6. So the ICDAS that identifies cavities, this is what we consider as the D component of the DMFT index. So in order to approach and approximate the original definition of DMFT index. Then for the plaque control, we use the simplified Green and Vermilion index, calculus index for the calculus. Gingivitis, for the gingivitis, we use the community periodontal index. We had a modified index of orthodontic treatment for the 12 and 15-year-olds. And we had the trauma, we evaluated the trauma prevalence using the modified Ellis classification. We use the ICDAS-2 because it's a more sensitive. Primarily, the main reason we use it is because it can classify caries in different groups. And we will see further down in the results how this is mirrored in the data, in the results. ICDAS 1 and 2, where is the incipient lesions of the enamel, they are considered as a healthy tooth in regards to DMFS or DMFT index. So the component, the D component, as I said earlier, comes from categories 3, 4, 5, and 6. So, besides the clinical examination of the kids, we wanted to have some knowledge about the attitude and the socioeconomic status of these kids. So we had a questionnaire that went along with during the study. The 5-year-olds, for the 5-year-old group, the questionnaire was directed to the parents, and they filled out at home. For the 12 and 15-year-old students, there was an interview after the clinical examination, and it was filled with somebody from the study. The calibration of the examiners, this is a very sensitive part and very copious part of the studies like this, especially if you're talking of implementing ICDAS index, which is more, it has more categories. It is more difficult to achieve consensus and agreement between the examiners. So every examiner received a folder with information about the index about 3 weeks before the training. The training session was 2 days. The first day there was a theoretical part. There was a presentation and discussion about the different things and issues of ICDAS index. And then there was a discussion on teeth that were in vitro. The second day, the training on the second day for the 10 examiners we have for the 3 age groups involved 15 students, patients that we had from their adjacent school schools from the university, that they visited the university. The examiners went through, examined these patients, and we got the intra and inter-examiner reliability for this group. And the comparison for the inter-examiner reliability was against one person we had for every group that was considered the gold standard examiner. So these are pictures from the statistical group. And the intra-examiner reliability was 87, and the inter-examiner 85%, which is quite high for an index like ICDAS. So in real life, when the exams were done with a child sitting, moisture control was done with and plaque removal with gauze. We used the dental mirror most of the times. That was disposable for sanitary and sepsis, antisepsis reasons. And we used a WHO periodontal probe that was used once every day. We used the SPSS statistical analysis package. The significance level was 0.5. And we used primarily known parametric tests because the distribution in the population was not equal. So the results for the 5-year-olds, here you can see the questionnaire, a picture of the questionnaire and the recording sheet. Also, we got the information about severe early childhood caries and different factors that affected them. We used for the definition of the severe early childhood caries, we used the American Academies of Pediatric Dentistry definition. So the 5-year-old group were 1,222 children. They were evenly distributed, 49% boys and 51 girls. The urban population was 62 and the rural 38. And also you can see the distribution of the educational level of the parents. I'm bringing in this information about the parental education level because throughout the study it was one of the strongest factors that influenced caries prevalence. So we have an idea how it looks. So the mean DMFT index was 1.48 for the 5-year-old group. And if you were to see the different components, 1.25 was coming from caries, untreated caries, and 0.23 from treated caries. So this is a very interesting thing, that there is a lot of caries that are for a 5-year-old kids that were untreated. And this is something we will see with the carie index later on. Also, we found out that 61% was, about 60% of the kids were caries-free. But the interesting thing was that 1.4, the index 1.4 teeth out of, in the population were in the group of ICDAS 1 and 2, in a sense, in a precavitated status, something that the DMFT or DMFS index will never show. And this is one of the reasons that this one information that we will get from ICDAS that's very important, and one of the benefits you have using this index. So here we see the carie index, meaning the percentage of the teeth that are treated compared with the teeth that are not treated, but they have caries, is only 13%. This is very disappointingly low. Another interesting thing is that there are two areas, one with the 5-year-olds, one in the very south part of Greece, here in Hania, which is a very low index, and this is in the northern part of Greece, which is a high index. Exactly why it happens, we don't know. And it's not consistent with the rest of the age groups. Another interesting thing is that the
disease among the children. So the prevalence of the dental caries, as we know, even in the GCC area, is higher than it should be. And still, although we are working on the prevention, still, which I do believe that we are behind. This dental caries, it has high impact on the social life, on the life of the children. And as you can see, I do believe this circle might be much bigger than this, and many things can be added to it, like sleepless nights, treatment costs, functional limitations, and impaired growth in children, impact of the general health. All this might be affected by the general oral health of the children. So dental caries can have a very high impact on the life and the general health of the children as well. So the key of reducing this side effects or the consequence of the early childhood care is to have an early management. Management is start by prevention, and prevention is not just to do the fluoride varnish and prophylaxis. Prevention should start from the pregnancy area, when the mom is pregnant. So we should target the pregnant mothers or to be mothers or pregnant ladies, that we should invite them for the educational lectures to make the awareness of the oral health before they get the baby. And prevention shouldn't start when they have the baby or when they come to the clinic itself. So early management, I do believe it starts with prevention, prevention, and prevention. The etiology now it has been expanded than it used to be before. The etiology now it doesn't include only the time, the sugar, the carbohydrate, and the brushing. The etiology of the early childhood care is now expanded. The social class of the family, educational level of the family, and the behavior and attitude, knowledge, and income, all these factors are affected and included in the etiology of early childhood caries. So when you have a child with the early childhood caries, you should always consider this socioeconomic status of the children. And where we have targeted, basically, these children, they were living in the jail. So this also might be a factor in the early childhood caries. So etiology is now expanded, and always look at the other factors that we used to look like having the diet and sugar. Yes, they are important, but many other background information like the socioeconomic status of the family are really quite important. So as we said, parents and caregivers. Parents and legal guardians, especially for the preschool children, they are the primary decision makers. So we shouldn't blame the children when they come to our clinic and having dental caries or abscesses. So parents and caregivers, especially in our countries where the parents might be working and the nannies are I can say that they are primary caregiver of the children. These nannies, we don't know how well they are educated. Are there any regular follow-up on how they are doing the preventive measures and brushing at home or no? So we should target these people also, other than the children, especially the preschool children. So parents and caregivers are really important factors in the prevention of early childhood caries for the preschool children. So what if one of the parents or the mother is incarcerated? When the parents' mother incarceration or maternal incarceration, it has been increased, and they have found that the number of the incarcerated mother is now increasing more than the incarcerated father. So although the number of the incarcerated or the number of the persons in the jail, they are more male than the female, but recently the incidence of the having incarcerated mother is more than the father. So however, do have any study or data, what impact on the child health or child well-being it has if one of the parents gets incarcerated? If the mother is incarcerated, there is a separation. And in some cases, in some countries, they do have the rule that allow the children to live with their parents, with their mother in the jail nurseries. So all these aspects need to be studied and figured out. And as per our recently literature reviews that has been done, there haven't been any studies done on the oral health of the children of the incarcerated mother so far. And the only studies that has been done for this kind of children, it's mainly because on the psychological impact of the being in the jail nurseries, and nothing on their health has been done. And one of the reasons of that is because of it's very hard to do this kind of studies. And to get the ethical approval and to go to the jails and look after these children and do the screening on them, it's very difficult. And that was one of our difficulties initially, to how to approach these children and going to the jail nurseries and doing this screening and preventive measures. And this parental incarceration is now recognized as an adverse childhood experience. And so we should know that, keeping in our mind, that these children they are not prisoners. So they have the same right of any child who is living outside these jail nurseries. So as we say, there is a global increase in the number of the maternal incarceration. So if the mother is incarcerated, so along with that, the children that who reside with their parents, with their mother in the jail nurseries is increasing. And recently they have found that, as we say, that we have 3% increase in the maternal incarceration annually than it should, than comparing to the men, which is 0.2%. So due to this dramatic increase in the imprisonment of the parents, researchers have become now interested in the consequences of this issue on the child's well-being, finding that it has a range of negative impact on these children. And targeting these invisible victims, it's a challenge for the researchers. So let's talk about now the prison nurseries. Many countries, although not all of them, unfortunately, many countries, they do provide prison nurseries where these children, they can reside with their incarcerated mother in the jail nurseries. There is two dilemmas. Some parents, they don't like to have their kids to be raised in the jail nurseries, and they prefer separation of the mother and the child. And some parents, they do prefer having the child with them and reside with them in the jail nursery and being them. And many of these parents who they go to the jail, they are pregnant mothers. So once they go to, many of these children, from our screening that we have done, most of the mothers of these incarcerated or children, they give birth in the jail. So they go to the jail and they are pregnant and they give birth in the jails, and their kids, they stay with them. In many, like most of these mothers of these children were from expats. They weren't local mothers, because local mothers or those who are from the Emirati mothers, they usually have some relatives to take care of them outside the jail, and they prefer separation between the mother and the child. But for example, an Asian or any country which most of the incarcerated mothers were Asians in our study, they don't have anyone to take care of these children outside the jail. So that's why our jails, they provide nurseries for them, for these children to take care of them. So let's review what are the rules and regulations worldwide. The World Health Organization states that people who are in prison have the same right to health care as everyone else. And the United Nations standards minimum rules of the treatment of the prisoners, the Rule 23 provides that a special accommodation will be made in women's institution for all necessary prenatal and postnatal care treatment, and that agreement shall be made wherever practicable for the children to be born in a hospital outside the institution. If a child is born in prison, this fact shall not be mentioned in the birth certificate. And the Rule 23 also says that nursery should be staffed by the qualified persons to be provided in case where the nursing infants are allowed to remain in the institution with their mothers. In the Latin America, the Bolivian Code of the Criminal Procedure allows children, here they do allow up to 6 years, which is one of the countries that they do allow the really old ages, because most of the countries we found that they usually allow up to the age of 2, which mainly until the child finishes breastfeeding period, and then they take them out of the jail nurseries. But in the Latin America, they allow them to stay up to the age of 6. And they found that they have around 2,000 children living in the jail nurseries, which is a quite high number. In Australia, the maximum age of children and the specific profile of the mothers vary from state to state, but the intent and philosophy are the same. That in certain situations, it is the best option for both mother and the child to reside in the jail nursery. While prisoners are responsible for the care of their children living in prison, the administration department should take reasonable steps to ensure a safe environment of children. Let's come to the Saudi Arabia. Although I would like to hear from the audience after the conference, after the lecture, to hear feedback, if any one of you has any experience with that. As per the article number 15 of the law of 1977, prisons state that a newborn in Saudi Arabia can remain with his or her imprisoned mother until she or he reaches the age of 2. So Saudi Arabia, they allow up to the age of 2. When the child reaches the age of 2, the child must live with his or her father or any other relatives. If the child does not have a father or any relatives, the prison authorities place the child in an outside orphan. So in the United Arab Emirates, where the country that I'm coming from, the rule, law number 43 of 1992 states a newborn. Here in UAE also, the rules say that the child can stay with his or her mother up to the age of 2, but the human rights always overcome this law of the prisons. So we have seen children, they live in the prison nurseries up to the age of 6. So statistics are not clear exactly on how many children are living in the prison nurseries and how many incarcerated mothers are there. But in 2016, which only the statistics are available, estimated a number of incarcerated women in UAE jail is around 920 in 2016. Of these, approximately 140 are mothers, which has been increased now. So let's review some press, and this is just forget about the Twitter advertising. I'm not advertising Twitter, but if this is a press about the Khalij Times, they have written an article about how Dubai police take care of the women inmates and their kids. And if we see here, they mention that there is a small clinic, a dining hall, and a hall for activities and events, an educational room, and area for reception and surveillance are also part of this the nursery. And also, he explained that new children will have the opportunity to be close to their mothers around the clock in a private dormitory, or will have the set of time for breastfeeding. The nursery also provides private play areas as well as a small medical center to take care of the children. The medical center which we have in our jail nursery, it's a very small medical center, and they don't have any dental chair there, but they do have a dentist which might visit rarely, like every 2 or 3 months. A dentist might go there and do the treatment, and most of the treatment is unfortunately extraction. And they signed an agreement to bring the professional nannies to take care of the children. The children stay with their mothers from 8 a.m. to 4 p.m. and the nannies take care of the children after 4 p.m. So we aim to study the knowledge of the caregivers, nannies, and also plus the mothers, because the children in the jail nurseries, the environment of the jail nursery is very complicated, because it's not only the mother who can take care of the children. The nannies and caregivers in the jail nurseries are the main, they have the main responsibility of taking care of the oral health or general health of these children. So this is another article in the national UAE news. They had an article written, "The children brought up in the women's prisons." Here they do summarize. It's a conversation of one of the prison mothers talking about her experience with being in prison and the conversation that went between her and her daughter. She says that, I still remember the exact date when my daughter asked me where we are. She was 2 years old, 2 years and 9 months. And I told her that we were in a 5-star hotel. This is how she explained to her daughter the prison nursery. She said that we are in a 5-star hotel. She just looked at me and told me, "Mama, why are you telling me lies?" So children, they are clever and they do know where they are. So they cannot do anything with that. They are in the prison, and some they get born in the prison and they stay there. So it's very, like psychologically, it has very high impact on these children. And she also said that I do not want my baby to pay the price. I wish to get out soon so she can grow up outside the prison. And she also said that I'm scared the day when I need to tell her where we are. Although she said that it's not easy to grasp the idea of being born in prison. So we had the introduction and the rules and regulation of these prison nurseries and children's where they live. So we planned to go and do a study on these preschool children of incarcerated mothers at the jail nurseries, and at the same time we tried to target the mothers and the caregivers and nurses on the oral health of this knowledge and attitude of the caregivers. But only we were able to get the ethical approval from the Ministry of Interior to approach the children and the caregivers. And unfortunately, we couldn't reach to the incarcerated mothers, and we don't have any data on them. But as we said initially, because these children, they live both with their mothers from 8 to 4, and after 4 they live with their nannies. So both of the nannies or caregivers and the mothers, they might have impact on the oral health of these children. So the aims of our study was to explore the oral health status of these preschool children of incarcerated mothers in the UAE prison nurseries, and also to assess the oral health and knowledge of the and attitude of the caregivers in the UAE jail nurseries. And at the end, we aim to suggest recommendations and assist with the formulation of scientifically validated policies for the jail nurseries. So we have included healthy preschool children of incarcerated mothers at jail nurseries. We have targeted 9 jail nurseries. The total number of the jail nurseries in the UAE, we have 9 jail nurseries. And the children who raised more than 6 months at the jail nursery were included. And all the caregivers at the UAE jail nurseries were also included in this study to evaluate their oral health knowledge and attitude. And as I said, unfortunately, we couldn't approach the incarcerated mothers to evaluate their oral health knowledge and attitude. So here's the study design of our study design. It's included in 2 parts. The first part, which is oral health of the child of these preschool children, we had a study group which were the children of incarcerated mothers, and a control group of children of preschool children of the same demographic data whom are not living in the jail, living with their parents outside the jails. They were our control group. So initially we have targeted 151 for the study group for our oral of the preschool children, and total have been included 128 children were included in our study of incarcerated mothers. And we have doubled our sample size on the control group to increase the power of our study. So the control group, they were 254 preschool children who were included in this study. And also there were only 45 caregivers or in the jail nurseries total, and all of them, they have signed the consent form to participate in the study, and all of them, they were included in the study. So we have given the interview questionnaire to the total number of 45 caregivers. So we had the training and calibration of the examiners. We had only 1 examiner, and duplicate examination was done. Preliminary exercise and pilot study was done, and study location and randomization. For the jails, we have targeted all the jails across the UAE, but for the control group, we have randomly selected from the primary healthcare services in the UAE. And data were collected and conclusion and recommendations were given to the Ministry of Interior, and from Ministry of Health and Ministry of Interior we had joint collaboration and meetings, and now we are pleased to inform that we have now a policy is made for the oral health of the in general, and for the jails, not only jail nurseries. So we have created a policy for the oral health, and we have more regular checkups and screening of the people in the jail and jail nursery. So for the preschool children, we have evaluated the DMFT of these children and compared with the control group. The care index, we have evaluated the care index, tooth extraction index, restorative index, and treatment need index. They were evaluated for these children. Regarding the oral health, we have used the gingival index, plaque index, and calculus index, which all are, it gave us the oral health of the children. And the oral health, it was, then at the end we have divided, either it's a poor or optimal oral health, or it's a poor oral health. So optimal and good, and poor oral health. So results is now interesting if you have a look at them. So we couldn't see a big difference between the control group and the study group in regards to the DMFT and caries. The mean DMFT, both were high. So although there wasn't any significant difference between the study group and control group, both DMFTs are considered to be high. And in the study group, the DMFT was 4.97, and in the control group, it was 4.48. And if you look at this bar chart, here's the prevalence of the caries. Caries, it was less in the study group than the control group, but although it wasn't any statistically significant, but both considered to be high in the prevalence. So almost around 90% of the children, they had caries. So a restorative index, which shows that how much of these teeth were restored, we can see there is a significant difference in between the study group and control group. In the study group, only less than 0.5% of the children had restorations done during the jail being in the jail nurseries, and most of these restorations, unfortunately, were only GIC and not a proper or final restoration. And in the control group, it's around 5% of the population they had, although it's very low, they had a restoration done. So the next index was the treatment need index. It was a statistically significant difference. We had almost around 15% treatment need index for the study group, and less than 2% for the control group. And care index, which evaluates how much care do they receive other than restoration. So there was significantly difference with very minimal percentage for the study group, 0.3, and almost around 5% for the control group. And tooth extraction index, p-value, as you can see, it's not statistically, it shows a significant, but tooth extraction index, it was almost double in the study group, which where the sample size was half of the control group, but the tooth extraction index is double of that of the control group. Because unfortunately, when the patients, they take him to the dentist, a general dentist, not a pediatric dentist also, a general dentist visits the jail nurseries every 2 months or 3 months, or sometimes every 6 months. So when the dentists go there, and whatever the complaint is, the only treatment is being done because of the low facilities, less time, and less skills of the dentist to deal with these very young children. And the only treatment is unfortunately done is the tooth extraction index. And we need to consider the early extraction of these primary teeth in the future consequences of the more orthodontic treatment needs, more dental anomalies and impaction might happen if these primary teeth are extracted in a very young age. So regarding the oral hygiene, Oral hygiene, as we said, that we use the gingival index, calculus index, and plug index. According to that, we have divided either the oral hygiene to be optimal or good or poor. It was a statistically significant difference between the both study and control group. In the study group, we had only 6% of the good oral hygiene, and 80% of the control, they had good oral hygiene. And from the total number, 93% of the children living in the jail nursery, they have poor oral hygiene. And we have found the plug score to be very high. And this plug score not only affects the oral hygiene score here, and it might be one of the reasons of having the high level of the caries. Because if we compare the environment of the restricted environment of the jail nurseries to the environment of a child who's living outside and having supermarket everywhere, having access to buy a chocolate anytime, with a child who is restricted in the jail, which they don't have any access to these outside sources of the cariogenic diet, it's considered to be high. So these environmental changes need to be considered as well. And then regarding the oral health knowledge and attitude of the caregivers and nannies in the jail nurseries, which we approach them, we have constructed a 16 questionnaire, and we have interviewed 45 caregivers. And this questionnaire was short, and it had 8 questions in the knowledge part and 8 questions in the attitude part. So as you can see, the questions varied, like asking about the prevention, asking about the diet, health, and the attitude, also reason for the gum bleeding, frequency of the tooth cleansing, so general prevention and oral health prevention and dental caries prevention questions. One of the questions was, what do you use in a bottle when the child needs to give a bottle, or when you use a bottle at night? And the options were milk, juice, water, and formula milk. Unfortunately, there is only 15% of the nurses, they said that they use water in a bottle at night. It's because of as we know, one of the reasons of the early childhood caries, which other than name of the child is the nursing bottle caries, is because of the having a cariogenic content in the bottle. And the most preferable content in this bottle is water, but unfortunately here they use 15% of them. They prefer using the water in the bottle. And formula milk, which has been researchers have found that it is a cariogenic. They use 91%. They use formula milk, and 84% they use milk, which is a fresh milk. And unfortunately, 40% of them they prefer to use juices. And when I went there, they had big jars of juices they can use and fill the bottles at any time. And I know in the GCC now, Gulf countries, we are very fan of Vim2 juices. So they had these big jars of Vim2 juices, and they can refill these bottles and give to children whenever they want. And they don't know how cariogenic this juice is. Although the Ramadan is coming, so I'm sure that I'm not against the marketing for Vim2. But having a big jars in the nursery and giving this to children, I believe it's a crime. So now we have evaluated the association between the level of the knowledge and attitude among the caregivers. We wanted to know, does the knowledge affect their attitude or no? On the right, or the left side, you can see this is those who had poor knowledge, and here it represents the negative attitude, and the blue one represents the positive attitude. So caregivers with the poor knowledge, they had only 48% of positive attitude, and caregivers with satisfactory knowledge, those who had higher knowledge on the oral health, they had around 80% of the positive attitude. So there was a relationship, direct relationship between the level of knowledge and the attitude of the caregivers. And we have, I published a book recently in 2017 about this oral health of these children in the jail nurseries. And this book does have the guidelines and protocols of which we have been implemented in the UAE. It took us like 2 years of writing this book, and I'm glad that it's now published. And it does target these children. We have discussed in this book also about the psychological impact of being in the jail nurseries with the incarcerated mothers. So, in conclusion, prevention, prevention, prevention. And always we have to go and look for the areas which is restricted and it's hard to reach to them. Jail nurseries are here and everywhere. And I'm sure that we do have jail nurseries in the Saudi, but so far I haven't seen any studies or any research done on this topic of the oral health of the incarcerated mothers, children and mothers actually. For those who are dealing with the adults, I do suggest them to go and study this kind of population and see where we are and what is the protocol of the jail nurses, because they are part of our community and they are not permanently there, and they are there and they are very keen to actually to listen to us. They are very keen to attend these educational lectures and oral health awareness sessions. And also we need to have a continuous education programs on the oral and dental health and prevention strategies. And actions need to be taken by the Ministry of Interior and particularly women's jail nurseries. So thank you very much for your listening. And my only reason for coming here was just to raise the awareness, and please look, those who are responsible for this, to see what are these children doing in the Saudi Arabia. And I really am glad, I'm very open to share with you my opinion, and the book is available, and we can share with you our protocol in the UAE Ministry of Health, which has and Ministry of Interior. The protocol is now set, and hopefully we start to do the second round screening to see if this awareness and prevention strategies were effective in these children or no. And thank you so much.
Dr. Anas, thank you, Dr. Anas, for this presentation. Really, it was very informative, and we enjoy each single word you said. Thank you so much. Thank you, Doctor. And we can have 2 questions from the male side. Any question? Female side.
Dr. Anas, thank you so much and welcome in KSA. I'm Dr. Amira, pediatric dentist from Cairo University. I just have one question.
Yes, please.
What about the child rights? Now we have known that the AAPD, the American Academy, had endorsed that patient rights or the child rights is very important. You talked about the jailed mothers. What about the child himself or herself? What's his opinion about that? He wants to stay or he wants to go out? Because you said a note, and I have personally touched by the words of the girl that she said, "Mom, why we are here," right? So did you think of just putting something on the questionnaire and the awareness or the practice about the child right to decide where he wants to be?
Yes, thank you so much. That's a very important topic. Child rights, it comes first, definitely. But the issue is that these mothers, which they are expats in the UAE, they are not the locals. So the issue is that where do they need to keep the child? They don't have anyone outside the jail nursery to take care of these children. And they consider this jail nursery to be the safest place for them to have their children with them. And the separation for very young ages, it's not really effective. It might have a negative, because I told you in the beginning, there is two dilemma. Either the mother, they prefer to have their children outside the jail to be raised with any other relative, or the father if there, or if they don't have anyone, the mother herself, she prefers to have her child with her while she's staying. She feels more safe, and she feels more comfortable to have her child with her. And yes, they do have the right, but they are too young to decide for themselves. Because usually these children are at the preschool age. They are below 6 years. So I don't think that they can decide for themselves to stay in the jail nursery or to stay outside. And we have other, like orphans, they do take care of these children if they don't have, but mothers, they do prefer to have their children with them than having a child who no one is there to visit them regularly. Mother is in the jail and the child is in orphanage, so there is a separation for a long time, and once they meet, they might know each other. Maybe the child will not know who is her mother. So yes, that's a very gray area, and for now, this is regulation. It's not a bad idea to have a nursery in the jail, because in some circumstances, there is no one to take care of the child. And I consider that to be a safe place for the children to be raised for a short time. Although the rules say 2 years, I'm happy the child to stay for 2 years, but not more than that. But in some circumstances, you cannot avoid that.
One more question, sorry for that. What about with the oral health educational programs that are implemented for these places or these facilities? Are they efficient, effective, or still under process?
Before this study, there wasn't any oral health awareness programs in our Ministry of Health or in the Ministry of Interior in UAE. I don't know about in Saudi Arabia. If you do, guys, you have this awareness to if you go to the jail nurseries to these people. We used not to have any this kind of like the oral health. It was the last thing to think about for this population of these vulnerable children. But after this study, we had the regular prevention session, and we have trained the nurses and nannies there, and we are doing our second cycle screening to compare now was that prevention, was that effective or no? So still I cannot give you the answer if the prevention strategy that we implemented was effective or no until I have the statistic results, but I do believe it has been worked since we started, and this continuing education is to be continued for a long time.
Thank you, Doctor.
Thank you so much. Thank you.
Thank you, Doctor. On behalf of the organizing committee of Riyadh Dental Meeting 2018, I would like to present the certificate of appreciation.
Thank you so much.
Our next speaker, Dr. Aisha Sumait. Dr. Sumait received her dental degree from Faculty of Dentistry, Cairo University, Egypt in 1999. Her master's degrees in dental public health at Boston University, USA from 2004 to 2006. She obtained the PhD at University of Alberta, Canada in 2016. She previously worked as the head of Holloway School Oral Health Program from May 2003 to June 2004. And she is a head of the Capital School Oral Health Program from September 2007 to June 2004. Dr. Sumait published research in refereed journals. She submitted abstracts to different international meetings, and she was also invited to give a presentation from local to international meeting. She is also a member of different professional organizations and associations. Please join me to welcome Dr. Aisha Smith.
Thank you so much for the introduction and thanks for the invitation. I really enjoyed it this morning. It was a tough morning, and I had really informative sessions. Please let me share with you some experience of Kuwait about school oral health program. And school oral health program, today's lecture actually, the first part of my the first presentation, in order to have a more insight about tomorrow's presentation about evaluation. So hopefully it's going to be light, and it's going to be short, and I'd like to have more interactive questions at the end. So please enjoy it, and feel free to ask me about anything about the program, so we'll be ready for tomorrow. So it is a long-standing school oral health program worldwide. In this presentation, I'll go through the history, the structure of the program, our vision, mission, and the population we are serving, objectives, type of services we are providing in the school oral health, and I'll touch the base of success and challenges in order to have it thoroughly tomorrow. So, as everybody mentioned this morning that it is the most prevalent chronic disease affecting the children and adults, and it is the 4th most expensive illness to treat. And the oral health promotion program showed a very solid evidence to reduce the burden of dental decay. School-based intervention and community-based community-based program also showed a great evidence for reduction of dental caries. Why? Because you are reaching the target population, right? It is the most prevalent way to reach your population in very small community. In school-based intervention, many activities and intervention can be used, like fissure sealant, fluoride varnish, education, and screening. So what about Kuwait school-based intervention, or SOHP as we call it? They started in 1982, long time ago. And a key person, he was a graduate student in Forsyth and Harvard, have seen the school-based intervention provided by Forsyth. So a pilot study started in 1983, and after that they expanded the program into another school of thought, the Scandinavian Denmark School of the Royal Dental College. And in during 1990 and 1992, you know that the invasion of Kuwait happened, so they had to expand to cover all over Kuwait. And they invited Kentucky University, Forsyth, and University of Copenhagen. And at that time, they allocated $10 million for a 3-year program. And after that, in 1999, they decided to have a standardized program instead of having different protocol, different school of thought. So why not having a standardized program to have it all in order to monitor, to evaluate, and assess. So a standardized treatment, prevention, and education protocol have been done. But in 2004, they revisit the protocol, and then they have decided to have more intensive prevention program. And then we have a new vision, mission, and values. Actually, those vision, mission, values, we had it 2 months ago, we have decided we have to remodel, revisit the protocol. So we do have the new vision about healthy community, improved oral health, related quality of life among population. And in order to do that, we have to do it through effective oral health promotion, prevention, and treatment protocol. And we are embracing the values of excellence, innovation, patient-centered care, teamwork, collaboration, evidence-based integrity, compassion. And how we did this? We distributed, a long list of values. We encouraged our colleagues to send their input in the program. So at the end, we have like a consensus. This is the values we have to have our work around. And what about the objectives? These objectives have been developed 2004 and is still valid. Our objective is to increase the children benefiting from the program every year, increase the awareness among the target population, primary stakeholders, children, parents, teachers, reduce the proportion of children with unmet dental need, and increase the proportion of children with caries-free and permanent and primary teeth. And our target population, children from 5 to 16 through the KGs, primary school students, and intermediate. Actually, the KG children, they will receive only prevention and education. And the primary school students will have all sorts of services provided by the school oral health. And the intermediate schools, mainly they have school students will have prevention as well as education. So how we are rendering the service and what's the structure of the organization? You can see that we are a joint venture between Forsyth Institute and Ministry of Health. And in the top 3 levels, you will find that this is the kitchen for the protocols, for the procedures, for the regulations. And at the end, you have in the bottom where they have hand in hand with working together in the education, training, and school oral health programs as a unit, and prevention and inventory departments. And when I mention as a unit, we are rendering the services through the school oral health programs, 6 programs, distributed in Kuwait in 6 governorates. So each program will have a program head, clinical supervisor, educational head, and prevention team leader, as well as a clinical supervisor. And the total number of human capital in school oral health is 800 staff, 195 dentists, as well as 438. When I remember the Dr. Saud, if I am not, if anybody can correct me if I'm wrong, he mentioned that you have many dentists, but not as many as nurses. I thought we have a problem with the human resource, especially with nursing, but now I'm really happy. So how we render these services? Through center-based clinics, as I mentioned, that every governorate have a center. And in this center, we provide the walk-in clinics. And then we have 91 school-based clinics, fixed clinics in the schools, and 41 clinics as a mobile clinics, having them into the schools. When we finish, we just wrapping it, and then we go to the other one. And one mobile van, actually we use it for publicity and, نطير فيه حق الكشخة مثل ما يقولوا الكويتيين. So it is 3 types of activities: treatment, prevention, and education. Each one have their own protocol, their own team, and their own, and their own objectives. We use fluoride varnish fissure sealant as a prevention. Education, we have education in schools as well as activities, outside activities. We try to be engaged with the people, then the outside the school and the outside their, in their comfort zone. So this is part of one-to-one education. The one on the right, the KGs, and in this classes as well as in the exhibitions. And we have many brochures. We are these brochures actually need-based brochures. So whenever we have like an event or we notice something new, like in the past, we did not have a daycare in Kuwait, but now every child in 2 years, you'll find him in a daycare. So we do develop new brochures according to the need as well. This is the fluoride varnish and sealants. And why prevention? Because it's cheaper. It's better. We are, instead of waiting for the children to come to your office, we are reaching them in their places because they might not show in your clinic unless they have a pain. And at that time, it is, you cannot do much to these kids. And it's going to be very invasive procedure. So as you see here, sealants cost $37, where single filling can cost $100. If you go to extraction, it's going to be like $200. And as I mentioned, 2004, we put more emphasis on prevention. So we started to seal non-cavitated lesion, early caries lesion, and it is like D1, D2. And we noticed from our surveys that 30% of the caries, it's non-cavitated and early caries lesion. So we were thinking about like, what about having the sealed? And in order to avoid any fillings or any fill and drill activities in future. So what kind of services we are providing in the centers? It is regular pediatric treatment, emergency treatment, and in the school we have like more emphasis on first permanent molar, and in the clinic, in the center-based clinics, we have extra like root canal treatment, interceptive orthodontics as well. And, we do have a training and research department, and it is useful for us because usually what we do is we are translating evidence. But when I'll give you an example, if you have like a sealant research about the efficacy or effectiveness, you'll find the range from 30 to 90%. So where do you fill in that 30 to 90? You have to have something related to your context, related to your community, and your resources. So this one way to have like an evidence-based related to our context, as well as to plan and implement, evaluate oral health programs, for future. One example we have, like we had a cost-benefit study, and we showed that the school oral health program child costs around $40, where in the OMOH, Minister of Health, they assigned $80 per child. So it is a cost-effective, cost-benefit thing. This is, you will notice that most of our publications around fissure sealant knowledge, it's about retention of sealants, relation between oral health, knowledge, attitude, practice, and primary teachers, because they are our secondary target stakeholders, because they are the host of our program. Also, school oral health became a proxy for education, continuous education. In the last 2 years, we've been like recognized like a center for a training and educational proxy, and it's recognized by the Kuwait Institute for Medical Research. As I mentioned earlier, I will touch base the success and challenges. And I would like you to just look at the blue bar in 2006 and 2012. You will find the blue bar, it's about the positive consensus among kindergarten students. And we reached like almost 50%. At 2012, we have 92%, which is double. And one reason for that, we institutionalized the consent form in the procedure of kindergarten registration. So if you are going to register your kid in kindergarten, they will provide, they will give you the consent form of school oral health program. So you'll sign it there, and we will obtain it from the school itself. That that helps to increase the positive consent return from almost 50 to 92% in 6 years. And if you notice that in 2009, 2010, we have a drop in prevention coverage, and it was like 40%. And if you remember, that year we had H1N1 thing. So again, preparation for emergency and other undesired events should be there in the school oral health, and it can be like a challenge for us. This is another indicator for us, the sealant versus composite. As I mentioned, we substitute the sealant on non-cavitated instead of having a composite. And you can see that there is a drop in the composite restoration and increase in sealant over permanent teeth. And another indicator, the DMF in 12-year-old, we stabilized the DMF. We did not decrease it markedly. This morning I had a chat with Dr. Rafi, and he said, after all these years, did you manage to have like a really low DMFT? I told him, just wait for tomorrow, and you will have better understanding about what's going on and why we are having all these barriers. And this is among the DMFT among 6 years old, and we have managed to make it lower, in one, like 2004, it was 6.5, and now it's 5.5. And if you remember that our target population from 5 to 16, so when they come to school oral health, they already have high DMF. So this is another challenge for us. And what about caries free? Because it was one of our objectives. We managed to increase it to 25%, among 12-year-old, and we, have, let's say, unsatisfactory result. We managed to increase it, but not as much as we want, and because of the children, come to the school oral health in the age of 5 or 6 and with high DMFT. And again, that's, ringing a bell in our head. We have to do something for children, preschool children. So what's the type of challenges we are facing? Standardizing the procedures all over Kuwait, it's a difficult little bit, dealing with 6 programs, 6 different population. I know that Kuwait is small, but we have some diversity as well. When we allocate the resources according to the population, it's not enough, because we have to consider another thing, population plus the oral health status among this specific governorate. Changing lifestyle, it's $1 million question. How we can change the lifestyle of our population. Definitely we cannot do it ourselves. As Dr. Abir this morning mentioned, it's a responsibility of the community. And I think, you know, when I was listening to the lectures, I said, oh yes, I know how she feels, because when I came back from the States, I want to transfer everything to, you know, why we're doing this. We can do this differently. And then we consider something like called context, local context. And this is a very important. And when we're talking about the context, we are talking about the economic, political, and social things, not just oral. And again, it is something we need a collaboration, a real partnership, not just alliance or, you know, and I'll talk about this thoroughly tomorrow, because tomorrow it's about evaluation of the program. You know, it's about why after all these years we cannot achieve our goal, or we cannot achieve the objectives as well. We are doing some good things. We know that we are putting a great effort, money, and resources, but again, why it's not there? So one of the challenges, the lifestyle, one of the challenges that the kids come to the school with high DMF. You know, one thing that we did not give any consideration to, the working days in Kuwait. I don't know about if you have the same problem in Saudi, and we have only 120 working days in schools. Can you imagine the regular working days is 178, 170, and we have only 120 days, and we have to have like this power dynamics things. They have competing priorities between our staff and the school staff. So this is another challenge. Absentee rate, around 50% of KGs. They have like less than 70 days. So this is another issue, how we can cover all these kids, and have them covered with twice fluoride varnish application in 70 days. Establishing culture of safety. This is another thing that, we always think about the oral thing. We always think about, one dimension, and there is, a third dimension we are not looking at. This is another challenge we are facing in the school oral health. So what's the conclusion and recommendation? I think everybody was saying since morning, prevention, prevention, prevention. And prevention, it is useful, and there are many solid evidence, yet we have to choose and customize the prevention we need for our local context. I do think, and I do believe that prevention in Riyadh will be so different than other places like Hail or Tabuk or another area. I think مثل ما تقولون أهل مكة أدرى بشعابها. We cannot just translate, knowledge from different part of the world, and we say that this will work here. We have to modify, and we have to have our own evidence. Prevention should be evidence-based as well as need-based. Combination of various prevention strategies is highly advised. And in order, in Kuwait we are doing like fluoride varnish and fissure sealant for smooth surfaces and occlusal surfaces. So we have to think about different, approaches. The thing that we are struggling with, oral hygiene. And when you look at the literature, you'll see that this is a prominent problem all over the world. There is no program have shown very effective result or outcome regarding oral hygiene. Monitoring and quality control. This is another area it's really underreported in school, in oral health prevention programs. It's really under evaluated. Good, let's say, research design for capturing the whole dimensions is really difficult, and it is underreported. Emphasis should be laid on changing the lifestyle, yes, but with cooperation with other sectors. We have to think ecologically, like we have to think about the individual, the family, the community, the regulations and policy. And I had really enjoyed this morning when Professor Abdullah Shamari was telling, we have to convince the decision makers. And I heard it once, like, you know, having the decision makers on board, thinking that this is a community problem. This is not a individual problem. Because whenever you are talking about something preventable, decision makers will say, this is an individual problem. They should take care of themselves. They should do this, they should do that. But in having a decision maker and policy maker thinking that this is a community problem, it's achievement. Thank you, and I'm happy to have your question. Again, I'm touching the base, you know, and I'd like to have your inquiries.
Thank you, Doctora, for this nice and valuable presentation. I really enjoy it. And now we open the floor for question, if there is any question. From the male side. Dr. Abdullah, you always take. And Dr.
Dr. Aisha, I'm really thrilled hearing this inspiring story about the success that you have made in Kuwait. One issue that bothered me, the cost of the program is a bit high. So do you think that, I mean, you know, now these days it's okay, but at one point we might have reduction in the budget. So don't you think that if we eliminate the treatment part of the program, that would reduce the cost, and then they will have more sustainable program?
Yes. I do agree with you 100%. But if you think this is high, this, the number I posted was 1980s. So now it's like 5 times higher. But the thing is, tomorrow I'll go through the decision making and how policymakers do, you know, taking their decisions. It is need-based. In a meaning community mapping for treatment. In Kuwait, when we started a pure prevention program. And then suddenly the treatment part started to increase. And you will find out tomorrow that only 25% of the staff working in the prevention, while 70% working in the treatment part. And there are 2 ways, because working in the schools, working with the mobile clinics, and working with the the young generation, when they graduate, they'd like to be in their own clinics, right? Not in the school-based or doing just prevention. This is one barrier. The second barrier, as I told you, that need-based and population need toward treatment more. That's why we had the center-based clinics and prevention. Now, just 2 years back, we managed to have like mostly 90% of the schools in the school-based clinics purely prevention. Before that, we have to have a quadrant, we have to have stand-C crowns, pulpotomies, and other procedures. And this, as you said, it's diffusion. We are not concentrating on prevention per se. But again, this is a secondary prevention and tertiary prevention. What we are trying to do now is to modify according to the need. As you mentioned, the cost is a bit high, but believe me, now it's almost 20 مليون كويتي يعني ايش كثر like almost 70 million, less than 70 million. But you know the population we are serving, like it's 300,000 kids eligible, and I say eligible to be enrolled in the program, but not all of them benefiting from just prevention. 90% they are having like school treatment as well as prevention. And you know, another thing that I will cover tomorrow, it's about the educational part. We are adopting knowledge practice and attitude model, and Dr. Anas showed that it's related, but when you just compare, like if you would try to find association between practice and attitude, you will not find it. And I always give an example, how many dentists smoke? Many, because you know, knowledge is not necessarily translating to a practice. So we have to adopt more theoretical models that related to behavioral changes, like theory of planned behavior or other health belief models and other things, in order to change the attitude toward practice.
تفضل دكتور أكرم.
Dr. Aisha, what an inspiring presentation.
Thank you.
The reason why I say that, because it's a lesson for us in Saudi Arabia to continue a program, like not to start something and we stop.
Don't invent the wheel.
Exactly. The second thing, Dr. Abdullah, where is he? Now, he talked about cost, and it's a valid thing nowadays, especially in Saudi. We're trying to cut, budgets from here and there. My suggestion, and I hope the people in this room can take it over to their places. Why not to use the interns, the dental interns in their year? I think in Egypt, they are mandated to do 2 years of community work in a remote area or something. We can do something similar to this as part of their rotation during their internship year, and then we can cut the cost. They're being paid anyhow.
I think you are totally right, and I'm a part-timer in Kuwait University, and unfortunately, reality bites. If our colleagues, like the other specialists, they don't believe in dental public health. They don't think that it is. We should promote for ourselves, like dental public health is the core for every specialty. They should be a dental public health person in the beginning. Then you will be a dentist.
Fifth and last presenter, Dr. Muhammad Al-Kilzi. Dr. Al-Kilzi graduated in 1997 from the University of Elbo. He specialized in pediatric dentistry in the University of Damascus in 2000 and from the University of Greifswald in 2007. In 2009, he obtained a PhD from Department of Preventive and Pediatric Dentistry. In 2013, he has taken up the position of Associated Professor in Department of Preventive and Pediatric Dentistry, Center of Oral Health, University of Medicine of Greifswald in Germany. Beside his involvement in educating under and postgraduate students, he is leading many research projects in preventive and pediatric dentistry. Dr. Al-Kilzi has published many scientific articles in English, German, and Arabic. He's also participated in editing some books in pediatric dentistry and cardiology. His point of interest is improving oral health in children and adolescents. Please welcome with me Dr. Al-Kilzi.
Thank you very much. Okay, dear Chairman, dear Organization Committee, thank you for having me here. Dear colleagues and guests, thank you for being here. Assalamu alaikum wa rahmatullah. I'm coming from Greifswald. Greifswald is a small university city in northeast of Germany, lays on Baltic Sea, 250 kilometers from Berlin. This is the old city center in Greifswald. This is the Baltic Sea before 3 weeks, so the people can go on water. And this is Greifswald in summer. Nice small city with ceiling boat. This is our dental school and clinics. It receives about 44 new dental students every year. And the evening, the elements of this presentation are dental public health service in Germany and German health insurances, tools for caries monitoring in the community, trends in caries prevalence in Germany, evidence-based preventive approaches in the community, intensive prevention for risk groups, and initiatives and projects which we did. First, about dental public health service in Germany and German health insurances. The federal laws organize the oral health for people and prevention at a group level, and also organize the prevention of oral diseases at individual level. The law define these three parties: the health insurance, Ministry of Health, and National Dental Association, in the responsibility for oral health of people, for prevention, examination, and evaluation, starting from kindergartens and schools. Here are some facts about German health insurance. 95% of people are covered by governmental health insurance that provides free dental examination for children twice a year and for adults once a year, and preventive procedures, caries prevention, periodontal diseases prevention, and most of dental treatments. The remaining 5% have a private health insurance that covers all of the same and more surfaces. Insurance is valid in all European Union countries. According to law, tools were developed for monitoring caries in the community. One of these tools is DIOT, the German Workshop for Dental Health. DIOT carries out national dental examination for children and adolescents every 5 years nationally and yearly on community level, covering Germany and carried out by calibrated examiners. This dental examination follows WHO criteria, registering DMFT for both primary and permanent dentition. In addition, initial carious lesions are also registered for both dentitions. The examiners involved in dental examination across Germany are calibrated. We developed online training and calibration program to train and reach almost the examiners through website and password for involved dentists. This online calibration is bringing very good agreement and better reachability to the examiners. Here we calibrated 480 dentists by last national examination. More we can reach more dentists as by on-site calibration in the former national examinations. The national dental examination targets children of 3 years old and 6 to 7 year olds and 12 years olds. These are the numbers of the cross-sectional sample. The results of the national dental examination give us the trends in caries prevalence in Germany. First, caries prevalence in 3 years old. About 86% of children are caries free, and the mean DMFT for 3-year children is about 0.5. And if we look to the remaining children with caries, except the caries-free children, about 15%, if we look to their DMFT, we see it is about 3.57, and we see here the phenomenon of caries polarization. This is the initial caries. The laser cannot, you cannot see the laser, I think. This is the initial, the index of initial caries lesions, 0.19. Here is caries prevalence. This here? Ah, okay, this is good. Thank you. Here is caries prevalence in 6 and 7 years old. About half of these children, are caries free. The mean DMFT is about 1.7, and here also in the caries carriers we see the DMFT of 3.97, and here is again the caries polarization in 6-year-olds. The caries prevalence in 12 years olds in Germany, we have 70 8% caries-free children, and the mean DMFT is 0.4. Also, we see caries polarization in the caries carrier children. This figure shows the development of caries prevalence in Germany last 22 years, a clear caries decline of 40% in primary dentition and of 80% in permanent dentition could be detected. And for the first time, we have the, on the whole of Germany, we have the caries index for 3 years old, here in the orange one. So we have no comparison before at the national level, but in the community, we have some results. This caries decline, which we saw, is in line with WHO targets for dental health in Germany. Furthermore, the targets of WHO for 2020 for permanent dentition are already reached and passed. For primary dentition, there are yet more to do. In primary dentition, although more than 80% of children are caries-free, the proportion of children with treatment needs is still higher than the proportion of treated children. As the preventive approaches at community level are financed and by state and taxpayers, these approaches should be lay on evidence. And the following are evidences for main preventive procedure in the community. The Cochrane reviews provide a high level of evidence. Here is a Cochrane review on the preventive effect of topical fluoride, showing a preventive effect of 26%. Furthermore, the review shows that the direction of effect was consistent. And about the use of fluoride gels, there is evidence that the fluoride gels with high fluoride concentrations, about 1.25%, used in school-based programs, have preventive effect of 28%. So this means 28% caries reduction. The left figure shows the pillars of dental health: toothbrushing, diet, and nutrition, and fluoride, and two recalls to dentists. Here, I have difficulties here to show. And in the right, but in fact, not all these components have the same effect. In the right figure, the same factors are demonstrated according to the evidence. We see that fluoride has the highest evidence-based effect. This study evaluated a preventive program for early childhood caries in a cohort of new birth in Germany. In the prevention group, parents of newborn children get dental health advice about diet and nutrition, toothbrushing with fluoridated toothpaste. Control group included children of parents they didn't have interest to participate. The evaluation time was 3 years. After 3 years, the results show significant lower caries incidence in the prevention group. in the prevention group than in the control group. According to evidence, we established a preventive program in kindergartens and schools. Accompanying with general health register, parents get for their child the dental passport as a register and guidance for child oral health with schedules for recalls. Since some parents do not visit dentists for their children, this preventive program is targeting children in kindergartens and schools. The coverage rate is very good for children between 3 and 6 years old. 91% of children, of 3 to 6 years children are covering in this program, but less coverage for children younger than 3 years old, as not all of this cohort visit kindergartens. This program consists of annual periodic dental examination in combination with basic prevention impulses in kindergartens and primary schools. The program covers almost all kindergartens and schools in the city, except one private school that refused to participate. The basic prevention provided consists of demonstration and training about age-compatible toothbrushing technique with fluoridated toothpaste or fluoride gel, fluoride instruction, diet instructions, and the aim is to achieve widespread daily toothbrushing in kindergartens and schools. For kindergartens and schools with high caries levels, an intensive prevention with more visits is provided. We provide midwives with training about instructions for pregnant woman and husband about oral hygiene from first tooth, re-tooth brushing, diet or supervising toothbrushing, diet, healthy nutrition and drinks, fluoride advice, oral bacterial transmission, and visiting dentist for checkup twice a year, and prevention from ECC. So they can give these instructions to new parents early after the birth. In kindergartens, we provide a training for the employees about caries prevention for children, finding and avoiding the sugar sources in kindergartens, and to restrict it to at meal time or but not in between, and to replace it with water or tea without sugar. Also, etablishment of daily toothbrushing with fluoridated toothpaste. Dental students are good cooperation partners for dental public health. Dental students, our dental students, they take patency for a kindergarten or school for 1 year. And dental public health office provides also parents evening about supervision toothbrushing. We called it re-toothbrushing, and advice for using of fluoridated table salt, using of fluoride gel weekly from first permanent tooth, and periodic visits to dentist twice a year. In primary schools, children get their first permanent teeth. Therefore, we do presentation of the prevention program on the first parents meeting, including oral health instructions about rebrushing, side brushing, or cross brushing technique for new erupting molars or permanent molars in eruption, and using of fluoridated table salt toothbrushing with fluoride gel once a week from first permanent tooth, recalls to the dentist twice a year, and informed consent of the parents for fluoride application in the school for entire school time. For more effective prevention, we offer weekly toothbrushing with fluoride gel under supervision of teachers. Toothbrushes and fluoride gel are provided by the Regional Public Health Office. We provide every school with at least 2 impulses every school year, including oral health instructions and fluoride application. For schools, in schools for children with special needs, we provide equivalent program to the universal schools, in addition to at least 4 intensive prevention impulses every school half year, patented by dental students, and weekly toothbrushing with fluoride gel under supervision of teachers. What are about intensive prevention for risk group? What are the risk group in the community? We, as dental caries is multi-factor disease, we conducted a multidisciplinary study to find possible risk factors for dental caries in school children in the local region. The results showed reverse correlation between caries experience and social class. This means low social class correlated with high DMFT. We found reverse correlation between DMFT and family income in euros. So families with high income, children from families with high income have less caries. And we found also reverse relationship between dental behavior and the DMFT rate, but positive association between the DMFT and the duration of daily television watching. So when children spending more hours in television watching, they have more caries incidence. Results from many studies confirm that caries is still a social disease. We see here children with high DMFT in both dentition in people with low social status and migrants in many studies, and also insufficient oral high rate of insufficient oral hygiene in the children from low social level. Here again, risk groups regarding times of toothbrushing a day and recall visit to dentist, small children and low social status and migrants tending to brushing teeth less than 2 times a day and to visit dentist less once a year. This study concluded that social inequalities was strongly linked with health inequalities, with more prevalence of caries, smoking, prolonged TV watching, and wrong diet habits among children of low social economic status. Hence, intensive oral health procedures should be directed to these risk children. Risk children demonstrate the new problem of caries polarization. 53% of 6 years old have naturally healthy dentition, caries free, and about 70% of 12 years old also are caries free children. The problem is in children with high caries risk, so-called caries carriers. 12% in 3 years old, 12% of children have 95% of caries incidence. And in 12 years old, 10% have 61% of caries index. ECC is a clear example of caries polarization. It is most chronic infectious disease in children, 5 times more than asthma and 7 times more than high fever. This figure shows ECC prevalence in some German regions varies from 7% to about 30%. In Greifswald, we lay on 9.5%. In Greifswald, we could define risk kindergartens with high ECC level. We applied intensive prevention program in these kindergartens, including presenting the intensive program, dialogue with personnel and director of kindergartens, parents, organizing parents meeting, and make preparations for appointment in advance, supplying with toothbrushes, toothbrush holders, and toothpaste, and special meeting with parents of ECC children, providing these parents with information leaflet about ECC to avoid it from occurrence by the second child. Toothbrushing in kindergartens is not an easy job, especially by small children. The personnel in the kindergarten should take care about hygiene and prevention of infection. Almost of children are cooperative in kindergarten to toothbrushing under supervision of the employees there, and our hygiene dentists also go to the kindergartens. The evaluation of this intensive program shows a clear caries reduction in 2 kindergartens and less reduction in the last one. Finally, I would like to present 2 initiatives for dental health promotion in community. The first one is an European project for prevention of infection in schools. This is the General Prevention of Infection program established in London and spread in European countries. Oral health is one part of this preventive program. Provides schools with learning materials and exercises about oral health. Exercises are provided in classrooms and for home using, such as brushing diary and diet diary, enhancing knowledge and practice for oral health in school children. The program has partners in most European countries. We are the German partner. We provide the materials in German language online for schools in German speaker countries, including the oral health part. There are also partners from outside Europe, such as from here in Saudi Arabia. This is Saudi team from microbiology department in King Abdulaziz University in Jeddah. The colleagues in Jeddah did hard work to transfer this program to Arabic, but the part about oral health is still waiting for a dental team. So please contact these colleagues and work with them to fill this gap in the program. The second initiatives we did 2015 is a mobile dental clinic for refugees at Syrian Turkish borders. We finished it in Germany, equipped it for wide spectrum of dental treatments. This picture was taken at the opening in Greifswald in Montessori School, one of the donators for this project, directly before sending the dental clinic, mobile dental clinic, to Syria. We equipped it, this is from inside, equipped with wide spectrum of treatments, especially pediatric dentistry. The dentist can make fillings, dental extraction, space maintainers, stainless steel crowns. We equipped it also with X-ray. And not only the providing dental treatment, but also beside the treatments, prevention is an important part of this work, of the work of dental mobile, providing children with toothpaste, toothbrushes, and oral health instructions in this Greece region. So thank you for your attention. Any question?
Thank you, Dr. Mohammed. Any questions?
Thank you very much for your nice presentation. I would like to know if you have a survey for 3-year-old children. Do you have it in Germany or no?
A set?
A 3 years survey for 3-year-old children. Do you have a survey for 3-year-old children?
Statistics?
Yeah, survey, national
survey.
Yeah.
The national survey,
yeah.
The national survey, which I spoke about it, it is the first time, 2016, we include the 3-year-old in it. Before that, every federal state of Germany, some of them did for the 3 years and some of them not. But in the whole national survey, this is the first time we did we include 3-year-old.
Okay, what I understood from your presentation that you have 2 kinds of health promotion programs, one for kindergarten and one for primary schools. Now, do you have any initiatives for younger children than kindergarten or?
So this is maybe misunderstanding because kindergartens in Germany,
yes.
Including also the nursery.
Oh, okay.
So the nursery is included in our kindergartens program.
So it starts?
It is start from
which age?
From the time, the age which children come to nursery.
Because what I'm thinking is we always, like a public health dentist, we always give advice for people to come to our clinic for prevention when they have their first birthday. So do you have anything related younger, I mean for younger age, like 1 year in Germany or no?
The most of children come to nursery or kindergartens in German from first years old.
Ah, okay,
first
so
year
it's
old,
included.
because the mothers take 1 year mother vacation, and then she should go to work. So she brings the child when he or she 1 year old.
Okay, why I'm asking, because Germany is a developed country, and usually in developed countries they go earlier. That's why I'm trying myself to tell people in Saudi we should start very early, like and very young, if we want to prevent caries, not at school time. So this is what we have.
No, we started also early.
But I had no idea. Early. That's why I'm asking you. Thank you very much.
Welcome.
Thank you, Doctor. On behalf of Riyadh Dental Meeting Organizing Committee, I would like to present this certificate of appreciation.
Thank you very much for the speakers and the chairperson for addressing this interesting topic. On the behalf of Organization Committee of Riyadh Dental Meeting, we would like to present the chairpersons with this gift. Dr. Ahmed Al-Qahtani. Dr. Sarah Al-Mubarki. Ladies and gentlemen, we have come to the end of this session for today. Thank you for your attention, and hopefully the presentations will be beneficial for everybody. I would like to remind you that tomorrow's session will start at 8:30 a.m. Thank you.